going to get started, I just want to start by welcome everyone to this series, AO Link, the first AO initiative directed solely at medical students. And this is episode 2 of a 10-part series. And we're just very, very excited to be with y'all again this month. And so whether you're in your 4th year of medical school, doing an away rotation right now, or you're in your 1st year entertaining the idea of orthopedics as a career, or if you're a veterinary or dental student, this is for you. This is to introduce you to AO as a group and a foundation, but also to some of the fundamental concepts that are going to serve you throughout your career. So as we continue the AO Link series tonight, we're mostly exercising the listening component of Link and the K, or the knowledge component. And so I just want to encourage y'all, the intent and construction of these webinars are such to have immediate integration, so immediate eye on your aways in the classroom and in cases. And then for many of us involved, the networking or interaction among each other and among colleagues is one of the most enjoyable parts of this. And so we hope you see some of that tonight between the faculty as well. So I just want to start by welcoming and introducing Dr. Rout, who is here on behalf of AO Foundation, and is a giant in medical education, and just give him a moment to say welcome and a few words to everybody.
Thanks, Dr. Mitchell. It's really nice to see all of you on, and I hope that you're enjoying the first and now the second one as well. This series was generated by just the ideas of some of our faculty in AO North America, and I represent AO North America as the current president. So I'm real proud of the sessions that y'all are going through, and I think you'll find them to be extremely helpful. So I hope that as you progress through your careers, you'll understand the value of being a part of AO, and particularly AO North America. And you guys have a great session tonight, and thank y'all for giving me the chance to welcome you.
Thanks, Dr. Rout, and Dr. Akers on a plane. He'll be joining us next month, I'm sure, for femurs, one of maybe his favorite topic of all. So again, I'm Phil Mitchell, and I'm at Vanderbilt, and I'm going to introduce and have Taylor introduce himself, and he's going to take us through session 2 tonight. So take it away, Taylor.
Thanks, Phil. It's great to be with everybody again. Just a reminder, my name is Taylor Young. I'm an orthopedic trauma surgeon at Texas Tech University Health Science Center, all the way out in El Paso, Texas. And I'm really excited to introduce our guest faculty today, Dr. Lucas Marchand. He is a orthopedic traumatologist at University of Utah. And a nice little fun fact, I rotated at Utah when Lucas was an intern there, and now look at us here.
Nice
Lucas,
little fun fact. Nice little fun fact. Lucas was my medical student a long time ago. So
there we go.
The roots run deep.
Lucas, will you tell us a little bit about yourself, and maybe give us some pearls for these students who are probably in the thick of away rotations?
Yeah, first all, thanks to AO North America and everybody, all the moderators of these sessions, for inviting me to be guest faculty. It's truly an honor, and kudos to you guys, because I think this North America Link thing is a really cool initiative for medical students. So I did medical school at the University of Washington, where I was a medical student under Dr. Rout. So life comes full circle. This is very cool for me to be part of a webinar that he's also teaching at, as he serves as the AO North America president. Then I did residency here at the University of Utah. I did fellowship on the East Coast in Baltimore, Maryland, trauma fellowship. And then back to the University of Utah as faculty. I think the number one pearl I would give to medical students doing away rotations or getting ready to do away rotations is 2 simple words, which is be engaged. You need to be engaged to figure out if this is your true passion, because this is hard work, but if you love it, it's the most rewarding work you'll do. So if you show up and you're engaged, you're going to show up early, you're going to stay late, and you're going to figure out if you really love this.
That's excellent advice. Thanks. Thanks for saying that. So just a reminder, this is the agenda for the year, and the topics we'll cover month by month. Just because this is only the second one, we really want to hash this out one more time for anybody who's just joining us. Our goals are, first, to provide you with a basic framework to understand how and why we're fixing fractures. so that you can build foundational knowledge throughout your career, because it's really a lifelong learning process. Secondly, we want to give you the tools that you need to succeed on your rotations, so that you can get the most out of those rotations and shine on them. So we're starting with some of the building blocks. Last month, we talked about how bones heal, and tonight we're looking at some of the details about the implants that we use on a daily basis. And we really hope that these discussions and cases help you grow and learn, and help you eventually make some good pre-op plans as we learn the language of orthopedic trauma together tonight. Just a reminder, your microphones are muted and your video cameras are off. We really want you to ask a lot of questions, be engaged. This is meant to be interactive, and just make sure you put your questions through the Q&A box. And then Dr. Mitchell will try to answer as many of those as possible, as well as some of our other moderators. And then don't forget to claim your badge for this session. And just a reminder that the videos will also be uploaded to YouTube a little bit later. And so just a quick recap on what we talked about last month. We basically learned that these are two similar fractures in the same bone here in the humerus. They were both treated with plates, but they healed very differently, as we can see. What we learned is that we had this acute injury, or this fracture, and on the left of the screen, it was a rather simple fracture. It was treated with anatomic reduction, absolute stability, and got primary bone healing. Whereas on the right, it was a more complex fracture, likely, and we sought length, alignment, and rotation with relative stability, and then the bone healed with a big callus there. And we also learned about the AO principles, which are basically the foundation of everything we do. And the main ones that we're thinking about here are anatomical reduction in the case of absolute stability, or length, alignment, and rotation in relative stability. We want stable internal fixation, and we want to preserve blood supply and respect the soft tissues. And the real goal of all this is to help patients, and that's with early, active, and pain-free mobilization. So we're going to recap a quick case here. One of the other things we learned about was this mnemonic to decipher x-rays. And so, Lucas, when you have a medical student, how would you expect them to present this x-ray to you?
Yeah, I really like this mnemonic that you guys went over last week, Walter, that Dr. Mitchell brought up. I think it really covers all of the sort of key concepts of reviewing plain film radiographs. So the way I like my x-rays read is essentially following this exact outline. So for me, it's first describing the images that you're looking at. So this would be two views of the right humerus. And then I like a description of what you're seeing in the x-ray. So two views of the right humerus. It looks like there is a simple transverse distal third diaphyseal fracture of the humerus without any obvious interarticular extension. And then I'm looking at the soft tissue, and I don't see any obvious soft tissue defect, which would suggest an open fracture, any other related injury. The elbow joint and the shoulder joint are not completely well visualized, but appear to be reduced. It'd be something along those lines.
Excellent. And what would you think about treating this with, or what would your strategy be there?
Yeah, so as you guys learned last week, simple patterns typically receive anatomic reductions under direct visualization. That is certainly the case in the humerus for me. So this would typically be a direct approach, an anatomic reduction with absolute stability. The fracture obliquity is not such that it looks like you can lag. So this would typically be achieving compression or squeezing the bone ends together using the anatomy of a plate, which is something hopefully you all will learn later.
Excellent. Phil, this was a nice case that you submitted. Can you walk us through what you did here?
Oh yeah, one of my favorites. So as Lucas said, overall simple pattern, transverse fracture. This technique with modified clamp drill holes is an absolute go-to for this. So we're exposing it, we're reducing anatomically, we're visualizing the fracture, we're compressing the bone with this plate, and Taylor's going to go over the mechanics of that in a little bit. And then I'd expect this to heal without callus. And this patient was back on the assembly line at Nissan in about 3 months. So if it were oblique or spiral pattern, maybe we would consider lag screws or another technique. But this is what we did.
Textbook. So tonight we have a few learning objectives that we want to cover. Essentially, this is like learning a language, and in this case, it's a language of osteosynthesis. I would be impressed if you can teach anybody a language in 1 hour, and so we're not really going to be able to do that, but we really want to focus on several specific objectives. In relation to screws, we really want you to begin to understand better the anatomy of a screw and how that informs its indications, as well as the certain types of screws that we use commonly. We also want you to begin to understand how plates work, specifically how we use them to compress, buttress, and bridge when we're treating fractures. And of course, we're going to apply this to fracture cases to reinforce those concepts. And then we want you to keep an eye out for the pearls that are really going to help you stand out on your rotations. It's easy to get overwhelmed when we talk about these things because there's a lot of implants out there, right? There's a lot of vendors. We use these implants in a variety of ways, but really the goals remain the same, and we're leaning on those principles. I know it gets overwhelming, and so what I would say is that after this, you may want to read a little more. You may want to read a little more next week, next month, what have you. These are some really excellent resources that are going to help you throughout your career. One of the really nice ones from the AO is this osteosynthesis app, and it allows you to actually virtually play with some of the topics that we'll talk about tonight. A little interesting pearl: many of you are paying for library access at your institutions as part of your tuition, and you can probably get online access to some of these textbooks as well, and so you can continue your reading in that way. The first thing we wanted to cover was basically what is a screw even? You might say, Dr. Young, I put together a ton of IKEA furniture. I really kind of know what a screw is, but it's a little more complex than that. And so a screw, by definition, is really a device that converts rotation into linear motion. Here you can see in the video, the screw is rotated, it's advanced into the bone, and ultimately can squeeze the fracture fragments together if it's been applied in the appropriate way. And this is one of the cool animations you can find on the osteosynthesis app. How does a screw do that? It's helpful to understand the anatomy to inform our understanding of how a screw accomplishes its function. And so first, we want you to understand the first objective, which is the anatomy of a screw. And I want you to really focus on three things here and really cement these into your knowledge. One is a core or inner diameter. In this case, you can see the core or inner diameter of this screw is 3 millimeters. And then the thread, or the outer diameter, in this case is 4.5 millimeters. And the threads are really what help the screw engage the bone. And the pitch is the distance between the threads of the screw here. And you can see that's 1.75 millimeters for this specific screw. And then it also has the head that is curved and smooth, and that helps distribute forces when you place this screw into bone. Anything about this, the anatomy of a screw, you maybe want to add, Phil?
Well, I think it's definitely helpful to know the terms and the anatomy, some of the basics, but really y'all will see this correlation, the application of these terms maybe tomorrow, maybe this weekend when you're doing a trauma case and a resident asks for the 2.5 millimeter drill, and they're going to put in a 3.5 millimeter screw. And the application of these terms is that drill, that 2.5 millimeter drill, correlates with the core diameter of the screw. And if you're going to put in a lag screw, like Taylor was going to go over, you're going to also need a drill with the outer diameter as well. And so I'd secondly just encourage you, take a screw next time you're in a case and just look at it. Look at the undersurface of the head. Look how it's smoothed and contoured in a way that would allow it to distribute force over the bone. Look at the tip, see if it's a sharp tip or a blunt tip as well. And these are great questions to ask either in this arena, but then also to your residents or faculty. And again, this is building blocks and really important concepts as we get going here. So
I may add
Excellent.
one thing to that, Phil, which is take two different types of screws and compare them, and ask questions to the people you're operating with about why one screw may be built one way. Why is a core diameter in a locking screw bigger than a cortical screw, and things like that. Stuff we may cover later, but also stuff for you to actively seek out, I think.
Perfect. Thanks, guys. So first, we're going to talk about lag screws, as we've already referenced, and we use lag screws to generate interfragmentary compression. That's compression between the fragments of the fracture, and this helps us achieve absolute stability and thereby primary bone healing. A screw like this is placed, by technique often, which results in that compression. And so the sequence of events is really important, and the surgeon controls that. Really, the first step is obtaining a provisional reduction and stabilizing that in some way. And then you use a drill that corresponds to the thread or the outer diameter of the screw, and that's going to drill your gliding hole. And then you take another drill. The size of that drill bit will correspond to the core or inner diameter of the screw, which you'll use to drill the far cortex. And this is your pilot hole. When you insert the screw, it's really only going to capture or gain purchase in the far side of that fracture in the far cortex. And so you can see here, this is the gliding hole. You see the shading there is wide enough to where the threads aren't engaging the bone there. And in the pilot hole, the threads are really interdigitated with that bone on that side of the fracture. And here's a nice little video that sort of demonstrates this technique. You can see here that a screw is going in first, and it's going to squeeze those fracture fragments together, or at least in this case, a gap will get squeezed together. And then we'll run through the sequence of how that's placed. In this example, they're placing a 4.5 millimeter lag screw, and they're starting here with a sleeve on the bone, which is going to protect your soft tissues because we have to respect the soft tissues. And the 4.5 millimeter drill bit corresponds to the core diameter, or excuse me, the thread diameter of this screw. And then the sleeve goes in, and this preserves your trajectory and also continues to protect the tissues. The 3.2 drill is then used to drill the far side, and that corresponds to the core diameter or the inner diameter. This is a countersink, which helps distribute forces in the head so that they're not too focused. Depth gauge is used to measure the length, so we're not putting in a really long screw and damaging an artery or a nerve or something on the other side of this bone. And then here's a little bit of an instrument you probably haven't seen, but this is a tap. We used to have to tap for all the screws we placed, but now we luckily have self-tapping screws, which have special flutes to clear bone and help the screw advance without needing to tap. Here you can see the screw is inserted. It's going to squeeze that gap together once the threads engage the far cortex, and the head is compressed against the bone on the near cortex. The other way we obtain absolute stability with screws is by performing a technique where we place lag by design screws, and these screws obtain compression solely based on the design of the screw. And you can really see the difference here. The screw on the right, you can see the threads extend all the way from the tip to the head of the screw, whereas the two screws on the left, they only have threads at the very tip. And there's an intervening portion that's entirely smooth until you reach the head. Now, in this case, the smooth portion of that screw acts as a gliding hole, and the threads will engage the far side of the cortex. One of the really nice examples where we use this technique is here in the pelvis, where when you have a posterior pelvic ring injury, we really need to close the gap at the sacroiliac joint. You can see the washer and the screw head are engaged against the ilium there, and the threads are within the bone of the sacrum. And as the screws advance, it closes the gap in the sacroiliac joint. We're going to talk about a quick case now. This is looks to be a fairly standard ankle fracture. What's an impressive student going to tell you when they present this case to you or talk about this X-ray with you, Lucas? What are some of the things that you're thinking about as you plan a strategy to fix this as well?
Yeah, so I think a good interpretation of this X-ray starts with the same rundown we discussed earlier. So this is two views of the left ankle, AP and a lateral view. And what we see here is a oblique or maybe even a hint of a spiral fracture of the distal fibula. And then if you want to go a step further, I think you describe the exact location in the distal fibula, because we think of the distal fibula in reference to where the syndesmosis is or where there is tibia and fibula overlap. And this is right at the level of the syndesmosis. Some people may have heard of the Logie-Hansen classification, and we would call this a Weber B. And then finally, in addition to that, you're seeing some lateral shift of the talar body and widening of that medial clear space. So the space between the lateral aspect of the medial malleolus and the medial aspect of the talar body. And that's important to note because that is ultimately going to be an indication for surgery in these injuries, because it becomes basically the equivalent of having a lateral malleolus fracture or a distal fibula fracture and a medial malleolus fracture. So when there's widening like that, we call it a bimalleolar equivalent injury.
Excellent. And when you're thinking about treating this, what's sort of your strategy?
And then in terms of treating this, we're looking once again at a simple fracture. So I'm thinking about a direct exposure of this injury, clearing periosteum and hematoma from the fracture site, getting an anatomic reduction, typically with a pointed reduction clamp, and then managing this with a lag screw and then some sort of plate, typically to protect my lag screw.
Perfect. So Phil, you submitted this case. Tell us what you did here.
Yes, thanks, Taylor. A couple of things to point out in the case. So in the first image on the left, you see a clamp on the fracture and the fracture line is dissipated. So pre-operatively, we identified an oblique fracture. That's a simple pattern, and we want to heal with primary bone healing. So we're going to open up the fracture site, anatomic reduction, and clamp it. And in the second image, you see we've applied a lag screw. And so I first want to address a question Annalisa just asked, which is a fantastic question, in terms of the sequence of drilling the near side and versus the far side. So are there times where you would only drill the glide hole first and then drill the far side, or a time where you would use the smaller drill of the core diameter, so a 2.5, and then hit it with a 3.5 in the cortex? And I think that's a great question. You're definitely going to see some different techniques for that. I think in the purest sense, if you drill the larger diameter first and are able to put a sleeve like Taylor showed in that video down that pathway, it will keep your pathway pure. And in bone that's particularly hard, cortical bone, you want, even if you're off just a degree, a half a degree, it can make a difference in terms of how that lag screw is going to work. So you'll see some variation. I think in the purest sense, you're doing near cortex first and then far, but certainly you can have some success doing it the other way. So in this case, we did a lag screw with that technique. This looks like a 2.7 millimeter lag screw. So that's the outer diameter. So we drill with a 2.7 millimeter drill first to the level of the fracture, and then use the 2.0 or the core diameter after. So Lucas, I put this screw in a little oblique to the fibula. It's a little cattywampus. It's not perfectly perpendicular to the fibula. Does that bother you? How would you have done it differently? Why did I do that?
Yeah, I suspect that once you guys had fully visualized the plane of the fracture, that what you're aiming for is to make your screw perpendicular or orthogonal to the primary fracture plane. The idea being, in the video that Taylor had showed earlier, being perpendicular to that gap that they were showing in the bone that was simulating a fracture allows you to achieve direct compression across the fracture site. Whereas if you're off axis, you will actually pull the bones into a non-anatomic position. So once you've placed the clamp and you're holding it anatomic, now you're looking at the fracture plane and you're trying to get an obliquity such that that screw will go into the fracture plane at a 90-degree angle, which is what I assume you were doing here.
Absolutely. And then finish it off with a neutralization plate, which we won't go into in depth today, but really it's a plate that's applied to neutralize bending and rotational forces around a single screw that we've just placed across the bone. So.
Excellent, guys. That was a great run through. So there are really a lot of different types of screws, and we talk about screws in a variety of ways. Here you can see a number of screws. We describe them based on their design, their size, various other characteristics, as well as where they're applied and what they're functioning as. Here you can see another long list of screw applications, and you can already get a sense of why this can be overwhelming. But we really want to focus on three things here. That was the plate screws, the lag screws, and locking screws. And so we're going to delve into those a bit more. Here, we're going to talk about the difference between non-locking and locking screws, because this is a really important thing to understand. And we really want you to focus again on the anatomy of a screw in this case. And so here you can see that the heads are very different, right? If you look closely, you can see the head of the non-locking screw is curved, it's smooth. and it's rounded, whereas the locking screw has a thread, has a thread on the head, and the top of the head is flat. And that's because those threads are going to engage into reciprocal threads on a plate. And the other differences here you can see are the core of the screw as well, and the threads. The locking screw has a larger core and smaller threads, whereas the non-locking screw has large threads and a small core, and that sort of contributes to its function. You can see in this image, as we blow it up for you to see even better, that as the locking screw is tightened, it engages the plate, and there may be a gap between that plate and the bone, and that's okay because the screw is functioning as an angular stability construct. It's a fixed angle device, and so it gets stability in a different way than a non-locking screw does, which relies on that plate squeezing down to the bone and getting some friction between the plate and the bone itself. The other thing we want you to understand is there are certain situations in which we may be more likely to use a locking screw. Commonly in our patient population, that's patients with poor bone quality, those with osteoporosis, and then the injury may determine that as well. Sometimes there's limited area for you to place a plate, such as in an injury that gets close to the articular surface, or sometimes you can't get a screw or can't place a screw that's bicortical. And you're placing a unicortical screw, such as in this proximal humerus, where there's locking screws that are directed towards that articular surface at the head of the humerus there. Phil, you submitted this really interesting case. Do you want to take us through this? You have time, or are we getting a lot of questions?
We're getting amazing questions, but I definitely have time to talk about this patient. So elderly female, and really she's not too elderly. She's 67 years old. And I think that's important as you y'all finish up your endocrinology blocks or get going on the wards, or you're in the middle of your away rotation and all you can dream about are plates and screws. It's just that sometimes these patients have other issues that we need to identify. So a 67-year-old with a rod already in her femur from a previous hip fracture, who has a fracture below that rod, she desperately needs to see endocrinology, bone health, someone to stop this. So I definitely want to point that out as y'all are getting going, and we're focusing on plates and screws and how to fix things that we are doctors too. So anyway, back to the case. I see a comminuted distal femur fracture below a long femoral nail. And I suspect this is probably from a prior hip fracture. And so we go back to the principles, and this is a comminuted fracture. And in that setting where there's also poor bone, an anatomic reduction or primary bone healing is not going to be possible or advised. So I'm going to look for some sort of strategy with relative stability, functional reduction. We want to get length, alignment, and our rotation correct. And I don't want to see her fracture. I don't want to visualize it. I want to put my plate on and actually just do it through as small incisions as possible and respect her biology. So in a metaphyseal fracture like this one, I want to use locking screws in the metaphysis. It's like putting screws in an eggshell. So you can imagine cortical screws are not going to have any purchase in an eggshell, but locking screw is going to have some function because it's locking into the plate. So in this case, we reduced her fracture. We applied our lateral plate. You can see all those distal screws. The bottom ones are locking screws. And then at the top of the plate, there's some variability. This is where we get to choose and select based on the patient. So here you'll see two types of screws that could be applied. In the shaft, you could put a non-locking screw like shown on the left side of the screen. And you can tell that's a non-locking screw because you can see the threads. It looks different than the locking screw. The head isn't engaged into the plate. It's at an angle that is outside what a locking screw could take. So Lucas, what's the blue plate special for you? Distal femur shaft screws. Is it locking screws? Is it a mix?
Yeah, it all comes back to the very first thing that you were talking about when you noticed or you were reviewing these x-rays, which is the overall bone quality of the patient. So typically these are cortical screws for me because the femur does have some of the thickest cortices in the body. But as you age or you have any sort of bone health problems and those cortices thin, I would lean towards more locking fixation. Typically, however, even in a situation where I'm planning to use locking screws in the metaphysis and the shaft, there's still some utility in using non-locking screws to help me bring my plate down to bone or if there's any sort of subtle malreduction and you're using that plate as an aid in your reduction, you can use a locking screw to sort of push the plate down to bone, aid in buttress over any sort of malreduction that you may have. And then subsequent to that, back up that non-locking screw with some locking screws to finish off your construct.
This one came out looking pretty good here, Phil.
Yep, everything went well. Secondary bone healing, callus expected.
We'll see. We'll see. So just a quick take-home message from our talk on screws here. We really want you to recognize when to use lag screws, and that's to generate compression between fragments and get absolute stability. And the two ways we accomplish this are lag by technique and lag by design. And design has to do with the features of the screw itself there. And then locking screws, we really want you to understand when it is best to use those and how they function. And we really want you to remember in poor bone quality and short segment fixation are the times when we are using those types of screws. Any important questions to address before we move on, Phil?
Definitely. I think one important concept is when to use lag by technique and when to use lag by design. And there's so many factors that influence the choice that it's hard to go into specifics. But to use an example, in the pelvis, like Taylor showed, we commonly use lag by technique screws. And that's because it's a single area, very specific area of bone that we want to put a wire in to make sure we're safe. And so that's a application of a lag by design. And maybe in a lag by technique or some of the cortical fractures that you've shown, where we can reduce it anatomically and the wire is not necessary. We can see the bone itself. We can see the reduction. And then we don't have to worry about putting a wire through cortical bone, which sometimes can actually be harder than just drilling it with a 3.5 and a 2.5 millimeter drill. So lots of factors influence it, and definitely some areas of the body you could do either, and some of it is going to be surgeon preference. So,
and some of it depends on access based on your anatomy and how much you can visualize the fracture for sure. So this is another interesting case. We're seeing another distal femur fracture here. We know those are pretty common. This case, the patient's an active smoker with a lot of medical comorbidities. And so what really stands out to you about this x-ray here, Lucas? And I guess, is there any additional information you need prior to making your pre-op plan? And what about their medical comorbidities influences your plan as well?
So you see two views of the right knee here. And I think what you see is a very low transcondylar fracture with a little bit of comminution. I don't directly visualize any intra-articular extension of this fracture, but it's something anytime a fracture approaches this proximity to the joint that I'm certainly worried about and would further assess with a CT scan. And then, as you alluded to, this lady's obviously very unhealthy. It looks like she's a multi-year smoker with a history of breast cancer and a litany of comorbidities, which starts to give you some insight into her bone quality. And now you're starting to feel exactly how Phil felt on his last case, wondering if cortical screws are going to do the trick, or if you're going to need to supplement with locking screws, or potentially additional fixation that you achieve via a different manner.
And so now we see that this does go into the articular surface. Is that going to change your plan, or can we still fix the joint, which we know we want absolute stability? Can we still do that when her bone quality is so bad?
Yeah, so the way I like to think about these injuries, now we have a CT scan. We note that there's frank intra-articular involvement, and a fracture that was relatively simple becomes slightly more complicated. But if you break it down into its parts, you can make each individual component of this fracture simple. So there was a simple intra-articular split. That's going to be addressed separate from that fracture plane that was going through the metaphysis of the bone, or that kind of low transcondylar split. So intra-articular fractures are typically addressed with direct visualization. So this is an open reduction, direct visualization. A clamp is typically applied, or you're going to attempt to achieve a provisional reduction and stability across the fracture plane. And then what you see here on the floral spot on the far left of this slide is lag screws placed across that primary fracture plane through the joint. Now we've secured the joint, and this becomes a metaphyseal fracture. So now I'm thinking back to how Phil managed his injury. This fracture again was low transcondylar, has some comminution, and I'm thinking the same thing as Phil. I don't really want to see the metaphyseal component of this fracture. I want to leave all that biology intact, the soft tissues preserved, and now I'm going to percutaneously manage this by sliding up some plates. You see in the bottom right-hand portion of this slide, once we had secured the joint and applied traction to the patient through the proximal tibia, we had reestablished the anatomic alignment to the distal femur, and we provisionally held this with cross pinning using K-wires.
Nice. Yeah, that's an excellent reduction there. And you ended up doing 2 plates. Phil only used 1 plate. Can you talk maybe a little bit about why your
Most talented.
strategy was a little different?
Yeah, strategy was different here. I think if you compare and contrast this case to the case that Phil took care of, there was less distal bone stock, particularly on that far medial side of this fracture. And so the addition of a medial plate allows you to get added purchase in that very distal fracture plane. So I think that was the idea and the utility of the medial plate in this patient.
Excellent. We're going to speed things up just a little bit as we get into plates here. There's a lot of different types of plates, but really the surgeon, not the designer of the plate, determines how a plate will function and how it will be applied. And so that's where your knowledge becomes super important. We're going to talk a little bit about the anatomy of plate as well, just like we talked about anatomy of screws. And once again, we really want to encourage you to look at a plate the next time you have an opportunity, because there are some features that are really, really important to understand. Here you can see this plate on the right has these recesses on the undersurface of the plate. Older plates didn't have this, but we learned that these recesses help preserve blood supply much better. And then when you look at the plate holes themselves, you really want to see that there's an inclined surface that looks like a little cylinder. And if you dropped a ball down it, it would slide down a slope. And then you also want to look at the holes themselves. And sometimes you'll see these little figure of 8 looking holes, which have threads on one side and no threads on the other. And we call these combi holes. And you can place a locking screw or a non-locking screw through that hole, depending on which end of the plate you put it through. But you can't do both. So we use plates in a number of ways, just like we use screws in a number of ways. And once again, it can be overwhelming if we tried to cover every single way we use a plate. But here we really want to focus on some of the most common, and that's compression here, which you can see this example on the top. Buttressing, those periarticular fractures, B-type injuries, get a buttress plate here, and bridging, which are some of the constructs that we already talked about a little bit, but getting secondary bone healing and comminuted fractures. So the first way we get absolute stability with a plate is compression plating. And you can see here we have a simple diaphyseal fracture of the radius. And we already know from last month's lecture, we want an anatomic reduction, absolute stability, and primary bone healing. But how are we doing that? How are we achieving that with this construct on the right? And so how does compression plating work? It's a little bit complex, but I think the best way to think about it is first, the plate's going to be fixed on one end of the bone, at least in a transverse fracture. And this screw can be placed in a neutral position in the center of the hole if you wanted. And then the screw on the opposite side is going to be placed by drilling eccentrically or in the far side of that hole, such that when that screw is placed, the head will engage that slope of the plate. It'll slide down that slope just like that ball did in that example, and then it'll cause the plate to translate horizontally, and that'll squeeze the fracture fragments together. We're going to run through another quick video to re-emphasize that. Here you can see they're placing a 4-5 screw. This is in a neutral position, which you can see in the right-hand corner is sort of in the center of that hole. And then they're fixing the plate to bone on the other side with a clamp here. Unfortunately, we can't do it just like this in the body, but it does provide a nice example. We're going to use the drill and drill eccentrically in the far side of that plate from that fracture. And the screw is going to slide down that slope again. And as it slides, it's going to generate the translation and squeeze those fracture fragments together. Here, one really important thing to notice is as this screw is tightened, that fracture compresses near the plate, but gaps away from the plate. And that's because the plate itself causes that deformity. And so one of the things that we do to prevent that is we pre-bend our plates. And so you can see here, this bent plate will negate that phenomenon and allow the fracture to be squeezed together symmetrically, rather than gapping on one side or the other. Really important point to note there. So Lucas, this was a case you submitted and you compression plated it. But what's sort of your strategy and your thought as you choose your plate, think about your construct, your screw sequence, things like that?
Yeah, obviously we've covered this again and again, but simple fracture, so direct exposure and reduction of this fracture. And then in terms of plate selection, you look at this, this is a young person with a diapsial fracture. You're going to have really good cortices of bone to purchase here. So in my mind, there's really no role for locking screw fixation. And additionally, that is not a technique which you can really achieve the same degree or type of compression you can with a non-locking plate. So this is a non-locking plate, small fragment plate. It has those contours on the undersurface to preserve blood supply, as you had mentioned a couple slides ago. And then typically the way this is done for me is a provisional reduction, similar to what Phil did earlier on that humerus case with a modified clamp set or a modified clamp. And then I will pre-contour my plate. So the plate has to both fit the anatomy of the bone and the anatomy of the fracture. What I mean by that is you can see there's a gentle bow to the radius in the sagittal plane. So you have to contour the plate in that manner first. And then I will put that apex bend right at the level of the fracture to achieve far side compression, secure the plate on one end of the fracture, typically the proximal end, and then drag the distal end of the fracture through eccentric drilling and compression.
Excellent. Thanks for breaking that down for everybody. Next up, we're going to run through buttress plating. Buttress plating is used to treat shear type injuries or split type fractures that are often in the metaphysis. These are often somewhat vertical appearing fractures. And so buttress plating neutralizes or protects against these shear forces. And that is accomplished by basically applying the plate in a way that it addresses the deformity 90 degrees to the axis of the fracture itself. And so here we can see there's a vertical fracture in the medial malleolus. And something I want you to know about is that this vertical medial malleolus fracture is part of a supination adduction type ankle injury. It makes us really sad to see this because we know the articular surface is impacted in the shoulder, the tibial plafond. And it's another one of those injuries you're going to want a CT scan and to better understand that. You can see that here's an example where that shoulder is really impacted, and that's part of the treatment regimen there. This shows the sequence for reduction and fixation using buttress plating. Once again, we've got a provisional reduction with wires, and then we're placing a plate with a screw at the apex of the fracture. We call this an axillary screw. It generates an axilla between the plate and the screw there, and that vertical fracture line is addressed and stabilized. And then once we've done that, we can actually place lag screws to further compress that fracture. And so you can see the bracket here shows 2 screws in the distal portion of that plate that are likely placed using a lag by technique fashion. And then the screw in the fibula can also be placed at similarly lag by technique as well and squeeze that transverse fibula fracture together. The last application of plating that we're going to talk about here is bridge plating. And we use bridge plating when we're thinking about addressing comminuted fractures. It's really helpful to think about it practically as you're literally building a bridge between 2 intact segments, and then the intervening area is undisturbed, basically like water under a bridge. And so this technique really, it works effectively to preserve biology in a comminuted fracture where we can't go in there and piece together every one of these little fragments, or we're going to devitalize that bone. We're going to strip a lot of soft tissue, and it's not going to be able to heal because we've disrupted too much of the biology. And so then we're looking at an indirect reduction where we achieve length, alignment, and rotation using cues both radiographically and anatomically, depending on the injury. And then our construct is going to be a relative stability construct, which is going to heal by secondary bone healing with callus, like we saw last month, and like we've seen in many of these examples already tonight. And so for that comminuted humerus fracture, we have to understand how bridging works. And so a bridging plate works by using a long plate, and that allows us to have a long lever arm, and that avoids significant bending force on the construct. And so this results in low strain at the fracture itself. So in a comminuted fracture, the way I think about it is that comminuted fracture is sharing the strain between all those little fragments, so nobody's really experiencing too much strain all at once. And we do this by utilizing a sufficient working length of our plate. And the definition of the working length is the distance between the two screws that are closest to the fracture. And this is a really important principle as we think about how we're modulating the strain in the fracture. So here you can see very comminuted fracture of that metaphysis of the proximal humerus. It was related to a ballistic injury. You can still see that in place. And here we've applied a plate with both locking and non-locking screws. But the key here is that we're bridging that area of comminution. We're allowing this patient to heal this with their own biology, and we've restored their anatomy based on length, alignment, and rotation. As far as we can use radiographic cues, their anatomy based on the insertion of muscles and tendons. And then you can see here at 6 weeks, the fracture's maybe starting to heal a little bit. At 4 months, it's really started to heal quite a bit. And then at 7 months, it's all healed, and there's abundant fracture at the site. Any questions coming up, Phil, that we should address before we dive into some cases?
I would say, yes. So the questions are amazing, and it's hard to cover all of them. And a couple of things. How do you select the plate size? How many number of screws above and below? I think there's a lot of surgeon preference for that. It's often dictated by the bone that you're plating. So we'll use this femur case as an example, if I can just dive right into the teaser from last week. But in the distal femur, commonly it's 4 to 5 screws above and 4 to 5 screws below, whereas the forearm that Lucas showed, smaller bone, smaller plate, 3 screws above, 3 screws below. There will be preference, and there may be some changes based on how severe the injury is, how poor the bone quality is. Great questions to ask during cases. These are like phenomenal. If a student asks me that during a case, I just turn to them, and the resident gets to do a lot because I'm there just getting really excited about how I selected where the screws went and everything like that. So anyway, back to the case, back to the teaser. This is a case I think that demonstrates really well some of the principles for the bridge plating. And in particular, I'll just note that, you may have the newest, fanciest plate that's on the market, but if you're not applying and using those same principles, it may still not work. So this guy took one step after 3 months of non-weight bearing and his screws broke. And so this is a great example of how plate length can affect the strain. And so Taylor mentioned the shorter plate that you have, the more strain is felt at the implant and more bending force. And so for this patient, they only had about three screws above the fracture site. And that for a femur is not enough. And so the plate's too short, the implant didn't hold. And so you mentioned the working length. This surgeon applied screws within the working length of the fracture. And so again, didn't follow some of those concepts, and unfortunately had a bad result. So we ended up fixing them up good and took the plate out and fixed them with a rod, and went well after that. But again, the purpose of this case to highlight the importance of plate length if you're going to bridge a fracture. So thanks, Taylor.
Absolutely, that's a great case, and we should talk about nails. We use nails commonly. We just didn't want to delve into all the details related to nails tonight. But you can see here, Dr. Mitchell used a nail, and that's basically functioning as a relative stability construct. Would you agree with that assessment? Absolutely. There?
Yep.
So case number 2, we see here, this is a 34-year-old male. He's a non-smoker. He's a mountain biker. He was injured in a mountain bike crash, and this is just a closed injury to his left leg. We know from the last cases, this is another distal femur fracture. are we going to treat it the same way as some of those other fractures that we saw in the distal femur? Are we going to be using a lot of locking screws to stabilize this injury? Lucas, this was your case. Is that how you're approaching it?
Yeah, thanks, Taylor. I think for highlighting one thing, which is that we've seen a lot of femur fractures, particularly distal femur fractures tonight, and you're seeing a lot of different ways of managing them. And the lesson that should drive home for all the med students attending tonight is that it's really the anatomy of the fracture or the that drives the treatment of these injuries. So you can see something automatically stands out about this femur fracture as compared to the ones we've previously seen, which this is a simple intra-articular or partial articular injury to the lateral condyle of the distal femur. So that's what we see on the two views, the AP and lateral views of the knee here. And because we know there's intra-articular involvement, it's frankly obvious on the plain films, but we may want to digest this further with a CT scan, which is what you see here. So the information I'm gathering from the CT are, one, is there any impaction, or is this truly a clean split into the joint, which it appears to be in this case? And then also getting an idea of what is exactly the plane of this fracture and where are going to be some sort of prime locations that I'm able to put fixation in an effort to get orthogonal to those fracture planes and get perfect compression across this injury. So that's the utility in my mind of the CT scan in this injury. So partial articular simple injury is going to be fixed, like we've repetitively said tonight, with the direct exposure and reduction. You see here on the left-hand portion of the slide, pointed reduction clamps being used to achieve an anatomic reduction, followed by 2 lag screws placed lateral to medial across that fracture in the distal joint. And then finally, if you saw in those 3D reconstructions of the CT scan, this fracture had a nice posteromedial spike, kind of an apex. And here I'm contouring a 4.5 millimeter plate in an effort to serve as a buttress to the apex of that fracture as added sort of stability to this fracture. And just like Phil talked about, I think about plate size for the most part from the elbow down. We're thinking 3-5, from the elbow up 4-5, and then from the knee down 3-5 plates, and from the knee up 4-5 plates.
In this case, you lagged the joint first, and then you applied your buttress plate. Do you think it matters which order you do that in?
I think if the reduction is anatomic, the order matters less. However, oftentimes you're using a buttress plate to aid in your reduction, meaning you've got it most of the way there, but perhaps there's still a subtle gap either at the joint surface or at the apex, in which case applying the buttress plate first makes a whole lot more sense.
Excellent. And I think, just to reiterate, this is a young patient, really healthy bone, really no indication for locking screws.
That's correct. That's a non-locking 4.5 millimeter low contact plate that, that has that scalloped undersurface.
And once again, absolute stability, compression right near the joint. We don't want callus forming in the knee joint. And so no callus, excellent result. Back on the mountain bike. This is a really interesting case that you sent in as well. This looks really complex. There's a lot of fracture lines there. It looks like there's 1, 2, 3 in the ulna itself, and then at least and 2 in the radius, it seems. And so this can seem like an overwhelming injury. And how do you distill this down into something that's more manageable?
Yeah, it all comes back to returning to the principles. And just like I said earlier, when we were talking about that distal femur that had an intra-articular split, and I was considering the articular injury separate from the metaphyseal injury in terms of treatment algorithm, I like to break down an injury like this in a similar manner. And that literally entails looking at each fracture in each bone and detailing the anatomy of that fracture. So if you really, with a careful appraisal, review these radiographs, you'll see that at each point where the ulna is broken, it's a very simple transverse fracture. Same in the radius. And so once I know that these fractures are simple, then I'm thinking again, direct exposure, anatomic reduction. And even though there's a series of fractures, I know that I can apply my plate in such a way, if I'm thoughtful about it, that I can still achieve compression across each one of these individual fracture lines.
Excellent. So that looks like what you did here. There's a lot of different size plates, a lot of different size screws. Do you think, is there such thing as too much?
There's definitely such thing as too much. The reason you'll see multiple plates on each bone here is because when you have a segmental diaphyseal fracture like this, and you're aiming for direct reduction and compression across these individual fracture lines, you've got to find a way to hold the bone out to length, or hold each one of those individual fracture lines relatively close until you can apply your plate and achieve compression. So what you see here are mini fragment plates that are basically spot welding each individual fracture line so that I can apply my larger 3.5 millimeter plate to do the bulk of the work in the compression. So those are really provisional reduction aids. They're still flexible. They're not rigidly holding the fracture, and I'm still able to achieve compression.
Real quick, Lucas, Alan asked a great question. When you're using two plates, are there considerations outside of the structures that are at risk that guide where that secondary plate goes, i.e., a medial and a lateral plate versus a medial and an anterior or posterior plate?
Yeah, obviously anatomical considerations. You're going to put plates on safe surfaces of bone. But beyond that, if we're saying, hey, I can put the plate anywhere, there's a lot of safe surfaces. How are you deciding? I'm typically thinking, what surface do I want the stronger plate on? I.e., where is the zone of comminution I want to protect, or where is the apex I want to buttress? And I'm usually using my stronger primary plate in that area for the biomechanical advantage that it provides.
I'm gonna skip through this case just in the interest of time. It's really just really quick. We did some lag by technique, or excuse me, lag by design screws at the joint, and then we're able to place a nail. And that gave us stability. But we want to give some time for some quick questions. And if Dr. Rout had any last minute words he wanted to share, any pieces of wisdom, quick plug, get your badge, videos on YouTube. Next month, get ready to hear about this crazy case. And don't forget to check out the OSAP application to learn more.
Hey, Taylor, so a couple of questions just before we close out. First, will you go back that one femur? Yeah, let's just leave it up here. Wonderful case. So just some questions to think about is over the next month, what's this nail made of? How long ago do you think it was put in? Is this a year ago, 10 years, 20 years? And then what do we do now that does not involve transection of the nail? We didn't do that. And it does not involve choosing the biggest, bulkiest medical student that's rotating with us to try to straighten out the leg. So there's that to think about. We'll also go over start points, types of nails, some other really good and fun topics. So one question that was asked about buttress versus neutralization plating, is that different? And the answer to that is absolutely yes. And then other than just having a lag screw. So a buttress plate is typically used in the fractures like Taylor has shown, those fractures that are secondary to shear, so a vertical medial malleolus fracture, the tibial plateau, and those are placed, you could put the plate and that axillary screw in, and that would hold the fracture reduced for some amount of time. So in that case, it's the plate and the screw that is being brought down to the bone that's resulting in the stability there, where a neutralization plate is placed to counteract forces across a lag screw that you've already applied. The fracture is reduced and you're putting the neutralization plate to obviate the forces around your lag screw. So they are different. There is no standard distance away from comminution whenever you're bridging. You're going to see a lot of variation with your attendings with this, and it's a great discussion point. In general, you don't want to be right where the fracture ends, because it's a long segment of comminution, but sometimes you're limited based on how extensive the fracture is. So a great point of discussion, and there's variability for that. So I guess that's the best thing. Last one, Lucas. Are patients that with intra-articular fractures at risk for post-traumatic arthritis, even if you get anatomic reduction, everything's perfect, are they still at risk?
Yeah, absolutely. Anytime you've sustained an injury to your joint, you're at risk. The reason being, there is some amount of articular cartilage damage that occurs when you have a fracture that is intra-articular that we can't see directly with our eyes, that can cause late sort of cartilage necrosis that I think can result in PTOA. So even if you do a perfect job, it's always worth making that consideration and noting that to your patients.
The cartilage is injured at the time of impact, would you say? Like I tell patients it got punched in the face.
Yeah, I tell them that it's bruised. It's bruised, and we don't currently have a great way to sort of bring it back to full health without letting the body do it. And sometimes I think it's bruised to the point that it's sort of unsalvageable.
Excellent. One last plug for the osteosynthesis app there. Make sure to check it out, and it can sort of reinforce some of these principles. All righty. Well, thanks so much for tuning in. Thanks so much for joining us. Next month, we're going to talk about femur fractures, like Dr. Mitchell said. And so get excited, because those are some fun injuries to treat. You guys have a good night.